much for the intro. So some quick background before we get into the CFD, because this study was done with CFD as well. High flow nasal cannula, or HFNC, ventilatory assist, is a non-invasive respiratory therapy in which heated and humidified flow is delivered to patients at higher flow rates than previously seen in conventional oxygen therapy. High velocity nasal insufflation, or HVNI, and we're going to be using these acronyms throughout the presentation today. This is a kind of a subset of HFNC in which the cannula prong geometry is modified, so it's a smaller inner diameter. So if you have the same flow rate as HFNC, it's going to be delivered at a higher velocity. Now, kind of two proposed benefits of this are higher CO2 flush, so kind of in between breath cycles, you're evacuating more CO2 from the upper airway, and then also the potential for higher pressure generation, descending pressure in the airway. So last talk we were talking about the more kind of down in the lower parts of the human respiratory tract, so down in the lungs. Now we're going to be moving it up a little bit, up to the upper airway. So kind of the base of the trachea up through the nasal cavity, oral cavity, and then there's actually a environment outlet in front of the patient's face. So really it's just kind of a rectangular prism extending in front of the geometry you see here to the right. And that just allows the patient to exhale and then actually re-inhale some of that flow if it doesn't get sufficiently far from the patient face. Since we're looking at kind of CO2 flush, re-inhalation of CO2 is something that we are very concerned about here. So we want to allow re-inhalation if it would occur. A quick overview of the boundary conditions that we're using in this model. So the airway inlet is in quotes because it functions as both an inlet and an outlet, because we have a user-defined function applied to the base of the trachea there. So we're tracking a realistic human breathing curve of somebody suffering from COPD. So it's a slightly increased respiratory rate, and it's more of a sinusoidal breathing curve, so it provides less time for CO2 flush. It's not an actual exact sine curve, of course, but you know, a healthy patient might breathe where it's kind of a quick exhale, quick inhale, and then this pause, or quick inhale, quick exhale, and then an adiabatic pause, where you actually aren't inhaling or exhaling for a short period of time, and that allows some CO2 to evacuate if you were receiving a ventilatory assist. But somebody who is suffering from COPD, some sort of respiratory distress, something like that, they probably wouldn't be kind of supplying that pause where you could flush a lot of that CO2. Moving to the cannula inlet, this is just a steady input of 100% dry oxygen at 35 liters per minute, and then the environment outlet is just a pressure outlet with a species feedback of 21% oxygen, so this is essentially just ambient air in the room. We're going to be looking at some contours of CO2 a little bit later, so I wanted to kind of show you what view you're going to be looking from. So the patient will be facing the right side of the screen, as you can see here, so you can see the outline of the patient face, the cannula, and then also the airway extending to the base of the trachea. Also, the contours were collected on multiple planes and then overlaid on top of each other, because you know if you're just looking kind of with this profile view and you just have one slice, then the nasal passageways are kind of careening left and right into and out of the page. So it would look like there were just kind of ends of passageways that actually do continue, but they would just go into or out of the page. So there are a few planes overlaid on top of each other to give you a more complete view. So now if we kind of allow the airway to kind of disappear a little bit, you can see an example contour shown here. Now this is colored by CO2, where red is high CO2 and blue is low CO2. So we want the contours to be as dark blue as possible. You want to flush out as much of the CO2 as you possibly can. So now if we completely remove the walls there, this will be kind of what you're seeing as we're looking at these contours. So previous work that we've done is we've looked at the distinction between these two ventilatory assist types at completely open and completely closed mouths. So now this is an animation of a complete breath cycle. You can see at peak exhale, CO2 kind of floods the upper airway. This is HFNC here. It's able to flush some of the CO2 out and then some of it is re-inhaled the subsequent breath cycle. But now what we want to do with this study, and then also continuing with future work, is we want to kind of fill in the gaps between those completely open and completely closed mouths. Because you would think, all right, well, if my mouth's completely open, I'm probably going to flush a lot of that CO2 out when I'm receiving therapy. If my mouth's completely closed, I'm probably going to retain a lot of that. But kind of where does the threshold fall for when you start to flush a lot and you can maybe close your mouth more and generate a little bit more descending pressure? So we wanted to look a little bit more fine-grained at the different mouth openings. So you might be thinking, this is CFD. You're saying you're going to be opening and closing the patient mouth. Is that going to involve remeshing, which would then introduce additional uncertainty? Because if the airway here, you're not going to be able to really get a really nice structured mesh in there where you know exactly what's going on when you change certain kind of like if you open the patient mouth a little bit and then remesh. So we wanted to avoid any unnecessary kind of uncertainty. So the way that we open and close the patient mouth is by essentially putting an internal face just behind the patient teeth and then splitting it into 7 distinct faces. And we took the total interfacial area there and then just essentially put ellipses on there at different percentages of that interfacial area. And then if we wanted to have the patient with a 20% open mouth, then we would take the kind of innermost 4 ellipses, 2, 5, 10, and 20%, and switch those from walls to internal faces so flow can pass freely through them. And then the rest of them would just be walls. So it's restricting the flow without having to remesh every time you want to look at a different percentage. So now moving on to some results. We're going to see 3 different groups of results here. So we're going to be looking at 2 therapy types and then 2 different mouth open percentages. So we have HV&I with 100% open mouth. Then we're going to close the patient mouth a little bit to 20% while still being HV&I. And then we're going to switch to HFNC at 20%. And we're going to kind of see the changes. So we collected contours at 3 distinct timestamps in the breathing cycle. So we have peak exhale. So that's just the point in the breath cycle when the patient is exhaling at the maximum volumetric flow rate. Peak CO2. So this is the point in the breath cycle where the most CO2 was present in the airway. And then end exhale, which is very important this is an important timestamp for how much CO2 we expect to be re-inhaled. So really this is the kind of the most important contour we're going to be looking at is the one on the right of the screen. So we want to see as much blue as possible. So like I mentioned before, you expect, okay, if you're receiving therapy and your mouth is completely open, you would expect a pretty significant amount of flush, and you can see that here. Even at peak CO2, much of the upper airway is completely CO2 free. So you see these dark blue regions up here, and then by end exhale, even the oral cavity is almost completely evacuated of CO2. But then if we close the patient mouth a little bit, we see the story changes a little bit. So we have kind of this high CO2 front that's indicated at peak CO2 there. So you can see at peak exhale, the CO2 reaches a little bit further into the airway. And then at peak CO2, that high CO2 front doesn't really move very much, but more of the CO2 kind of diffuses into the rest of the airway, and the concentrations increase a little bit up there. But then even with the 20% mouth opening, the therapy is able to recover by by end exhale, and much of the upper airway is flush by then. So you see not much change from 100% open to 20% open for HV&I. Now if we switch therapy types to HFNC, you can see the retention of CO2 is increased. So this is at the same flow rate as HV&I. They were both run at 35 liters per minute. So you can see that more CO2 enters at peak exhale. At peak CO2, much of the upper airway is filled with kind of the stale CO2-rich exhaled flow. And then by end exhale, the therapy does partially recover and is able to evacuate kind of some of this upper airway here and force some of that CO2 out of the partially opened mouth, but it's not able to fully recover. So then whatever's left in the airway would be expected to be re-inhaled the next breath cycle. So now if we look at this data plotted, what you're seeing here is on the left-hand axis, you see CO2 remaining in the airway in milligrams. So these four curves, HVNI 100, HFNC 100, HVNI 20, and HFNC 20, that's the therapy type, and then the mouth open percentage. And then in blue is the volume flow rate. So that's just showing you what the patient breath cycle looks like. And that volume flow rate is on the right-hand y-axis. So when the volume flow rate is 0, that's the transition from exhalation to inhalation, and that's labeled, that's indicated by the vertical black line saying end exhale there. So notice kind of as the curves cross this end exhale line, you can see that there is a significant difference in the variation between HFNC and HVNI as the mouth is closed. So for the HVNI curves, you can see the red and the yellow for 120. You can see that the shape of the curves are pretty similar, even though the HVNI 20 reaches significantly higher maximums. So you can see kind of this approach to the peak CO2 retained, a little bit of a flat line, and then they kind of drop off, and especially the HVNI 20 kind of sharply drops off as the volume flow rate is decreasing. And you can see by end exhale, there's not too much distinction between the two, maybe about 1 milligram of CO2 in addition retained because of the closing mouth. Whereas HFNC, you can see when you're changing from 100% mouth completely open to 20% open, the shape of the curve actually changes, where for the purple curve, HFNC 100, you can see kind of this sharp increase as you're going to peak exhale, and then it quickly begins decreasing and tapering off down to kind of right in between the two HVNI models. Whereas when you start closing the mouth with the HFNC therapy, that peak CO2 shifts significantly later in the breath cycle. So it requires that the volume flow rate actually decrease more before it can begin evacuating that CO2 out of the upper airway. And then that essentially removes some of the time required for the therapy to recover. So that kind of manifests in this significantly higher end exhale value. So where it was a 1 milligram increase, now it's maybe a 3 to 4 milligram increase because of that closing mouth. So now we're going to be switching the topic from CO2 to pressure. So we looked at CO2, you know, as you're closing your mouth, you're going to retain some more CO2. But I did also mention in the beginning, as you're closing your mouth, you're going to be generating a little bit more descending pressure. So depending on what you're looking for, you might want to either completely close your mouth or find some happy medium where you could be getting a little bit of the benefit of both. So instantaneous pressure data was collected at the airway inlet. So it was area averaged over this plane in the base of the trachea. And this was actually adjusted using the equation of motion of ventilation that's shown on the screen here. So the lung pressure, it was kind of treated as like this feedback from the lung, essentially. So this is dependent on the lung volume, lung compliance, lung resistance factor, and then the volumetric flow rate into and out of the lungs. So now we see a pretty similar plot to what we were looking at for CO2, but now it's just instantaneous pressure for 5 different HVNI models, just as we're closing the mouth here. These pressure signals, they may look very smooth, and you say, wow, that's a lot smoother than I would expect. Something like an instantaneous pressure, I would expect it to be a lot noisier. These were smoothed in post. It was a pretty noisy signal, so we tried to kind of find a smoothing window where we're looking at enough data points to the right and the left to remove these high frequency noise from the data, but we're not looking at so many points where we dampen low frequency oscillations that we would expect throughout the breath cycle. And also the number of models that was run total was reduced. If you remember, there was a 0% open and a 2% open, and then also a 40%. We ran a course model study to kind of find some areas of interest, and that's why I also showed CO2 information at a mouth open percent of 20%, because we found that was kind of a more interesting mouth opening to investigate, where there was some distinct differentiation between the models. Also, positive end expiratory pressure, which was introduced by the previous speaker, so thank you for that, is indicated on the plots here. So that's what we're going to look a little bit more at. So PEEP is a value used to indicate pressure at the end of each breath cycle. And there are some consistent trends established here when we take those instantaneous curves and kind of just reduce it to PEEP for HV&I and HFNC. So HV&I consistently promotes higher pressures than HFNC, and also, as you would expect, smaller mouth openings promote higher pressure as well. So, in conclusion, we did use some CFD models to illuminate the effects of non-invasive respiratory therapy on CO2 and pressure. And the reduction in patient mouth opening inhibited CO2 flush, which we would expect. But then HFNC actually struggled more as we were closing the mouth than HV&I did. HV&I also consistently produced higher PEEP than HFNC for a given mouth opening, and PEEP increased with decreasing mouth opening. So to kind of contextualize some of the information that you saw for how much the CO2 increased, the difference in milligrams between HFNC and HV&I would equate to roughly 24% of the airway geometry that we were studying being filled with this stale CO2-rich air that we were looking at. So that would be indicated by the red flow in the contours. So it is a significant amount of exhaled air to re-inhale the next breath cycle. So ideally, clinicians would instruct patients to breathe probably at some intermediate mouth opening, depending on what they're looking for. If they're more worried about CO2 retention, then they would simply instruct the patient to open their mouth more. If they were more concerned about pressure, then they would have them close the mouth. Thank you very much, and are there any questions?